Comenzamos entonces, ¿te parece?
Perfecto.
Súper.
Bueno, entonces, buenas noches para todos. Ustedes me excusarán que estábamos como enredados porque en este caso
Como
tenemos
gustes, yo me voy a
traductora.
demorar hablando unos 45 minutos.
Ya. Wait a
Sí.
second.
Estábamos un poco confundidos porque estamos como seminario web, entonces no estamos viendo a los participantes, pero los estoy saludando. Ya veo que tenemos 26 participantes. Queremos darle una bienvenida por parte de la Junta Directiva de la Asociación Colombiana de Ginecólogos Oncólogos. Tenemos hoy la presencia de la doctora Kathleen Schmeler, autora principal del trabajo Concerv sobre tratamiento conservador de cáncer cervical temprano de bajo riesgo, publicado en el International Journal of Gynecological Cancer en octubre del 2021. Tengo como moderadora a la doctora Angélica Fletcher, quien hará la presentación formal de nuestra invitada. Y para todos tenemos traducción simultánea. Para los que quieran escuchar en español, abajo en sus pantallas aparece como un mundo, como un globito que dice interpretación. Ustedes abren ahí y ponen español y oirán y escucharán a la traductora. Terminada la conferencia tendremos preguntas. Ustedes pueden levantar la mano, pueden ponerlas en el chat y posiblemente pues se pueden hacer directo. Si no, pues se harán en el chat. Y por favor a los asociados de la Asociación Colombiana de Ginecólogos Oncólogos, una vez terminemos el evento, esperar que tendremos la rifa prometida de las 2 inscripciones a la IGCS. Doctora Angélica tiene la palabra.
Okay, so welcome everyone. Thank you for being connected today. We have a very special guest, Dr. Kathleen Schmeler. Dr. Kathleen Schmeler is a professor of the gynecologic oncology at the University of Texas MD Anderson Cancer Center. She provides care to women with gynecologic malignancies, including surgery, chemotherapy, and preventive service. Dr. Schmeler is also the director of the MD Anderson Cancer Center and Lyndon B. Johnson Hospital colposcopy clinics, where she treats women with pre-invasive cervical, vulvar, and vaginal disease. Dr. Schmeler is also the executive director of global oncology for the MD Anderson Cancer Network and chairs the training and mentoring committee of the IGCS. She has authored and co-authored numerous articles in peer-reviewed journals. Her research interest is in cervical cancer prevention and treatment, particularly for resource-constrained countries and medically underserved communities in the US. So it is an honor to have her here with us. Today, she is going to talk about conservative surgery for low-risk early-stage cervical cancer, focusing, like Dr. Lucrecia said, on the Conserv trial. As you all may know, she is the lead researcher of this important study, for which I also have to acknowledge the participation of our Colombian colleagues, Dr. Rena Pareja and Gabriel Rendon. So welcome all, and welcome Dr. Schmeler. Thank you for taking the time to share with us your knowledge today and the insights of this important study. And without further introduction, the mic is all yours, Dr. Schmeler.
Wonderful. Buenas noches, hola a todos. Muchas gracias por la invitación. Yo voy a hablar en inglés porque mi español es muy malo. So muchas gracias a Christina for interpreting tonight. Can you see my slides?
Yeah.
Yeah, you can.
Perfect. Okay. So thank you again. I'm excited to present the results of the Conserv trial. This is a prospective trial of conservative surgery for low-risk early-stage cervical cancer. I have no financial disclosures. And we were very fortunate to publish our study just a few months ago, last October, in the International Journal of Gynecologic Cancer. And just for a little bit of background about the study, The standard of care for early stage cervical cancer is radical hysterectomy or radical hysterectomy for women who desire fertility preservation. Both of these procedures require removal of the parametrium, which contains autonomic nerve fibers that are associated with bladder, bowel, and sexual function. These surgeries are also associated with many complications, hemorrhage, bladder, ureteral injury, and fistula formation. And then I think something that's very, very important when we talk about cervical cancer is that a radical hysterectomy or radical trachelectomy requires a doctor with very specialized training in gynecologic oncology surgery, which is not available in most parts of the world, particularly in low and middle income countries, but also within countries, even including the US, where in rural areas or remote areas where they don't have specialists in gynecologic oncology. There have been many retrospective studies that have shown that less than 1% of patients who have very low risk tumors or favorable pathologic characteristics actually have parametrial involvement when you look back on the radical hysterectomy specimens. What retrospective studies have also shown is that 60 to 65% of radical trachelectomy specimens have no residual disease after a diagnostic cone is done. So when we started this study, our hypothesis was that radical surgery may not be required for low risk early stage cervical cancer. So we started a prospective study to evaluate the safety and feasibility of performing conservative surgery in women with early stage cervical cancer with favorable pathologic characteristics. Our secondary objectives were to evaluate recurrence rate at 2 years, determine the rate of residual disease in patients undergoing hysterectomy after a conization, to determine the rate of pelvic lymph node involvement, and also to assess quality of life factors. So this study was prospective, single arm, multi-center study. The sample size was 100 evaluable patients. All the pathology specimens had to be centrally reviewed at MD Anderson by our pathology team here. And our study was monitored by the MD Anderson Data Safety Monitoring Board. These are the criteria, and these are really important because this is how we define low risk, favorable pathologic characteristics. So the patients had to have stage 1A2 or 1B1 cervical cancer. And we started the study so long ago that we were using the FIGO 2009 criteria. But essentially, they had to have a tumor size less than or equal to 2 centimeters. And this was by exam or by imaging or by pathology. So if anything showed it was more than 2 centimeters, they were not eligible. So if you had a patient who you examined and you said, oh, it's 2 centimeters or 1.8 centimeters, and then we have an MRI that showed 2.5 centimeters, they were not eligible. Everything had to be 2 centimeters or less. They could not have lymphovascular space invasion. It had to be squamous cell histology, any grade, or adenocarcinoma, grade 1 or grade 2 only. So we excluded grade 3 adenocarcinoma. Every patient had to have a cone. It could be a LEAP or a cold knife cone. And the margins and the ECC above the cone had to be negative for malignancy. Patients were allowed to have 1 repeat cone and ECC performed if they to meet these criteria. They had to have negative imaging, either CT scan, MRI, or PET, so whatever was available at the study site, that had to be negative for metastatic disease. And then they had to have cone margins and an ECC negative, not just for cancer, but also for CIN2-3 and adenocarcinoma in situ. And then they also had to have tumors with less than or equal to 10 millimeters of stromal invasion. And I'll talk a little bit about the last two because those we didn't start with at the beginning. Those were added during the life of the study. patients had there were three surgical options, and it was not randomized. This was based on what the patient wanted and the physician. So the first was women who wanted fertility underwent a cone and ECC, and if they were eligible, and if they weren't yet, they could have a second, one repeat cone ECC. But once they met eligibility criteria, they then went another surgery where they just had lymph nodes removed. So essentially they had a cone and lymph nodes, or maybe two cones and lymph nodes. And with lymph node, pelvic lymph node assessment, they could have any of the following. You can see at the bottom of the screen, either a full pelvic lymph node dissection, which was the standard of care. They could have just sentinel lymph node biopsies, or they could have sentinel lymph node biopsies plus a full dissection. And that was up to the study site and the surgeon, because especially when we started the study so many years ago, some places were doing most places were still doing full lymph node dissection, but over time, many sites, including ours at MD Anderson, moved to sentinel nodes only. So that was the first group of patients, so cone and nodes. The second group was women who did not desire fertility preservation. So they underwent a cone still, an ECC. They could have a second repeat cone if needed. And then if they were eligible, they underwent another surgery where they had a simple hysterectomy and lymph node assessment. So again, not a radical hysterectomy, but a simple hysterectomy. And then we had a third group of patients that we all see commonly in our practices, but these are patients who had undergone an inadvertent simple hysterectomy with a post-op diagnosis of cancer. So these are women where they had a hysterectomy, someone didn't know they had cancer. The final pathology showed cancer, but they still met the criteria. The tumor was less than 2 centimeters, the nodes were negative, or the margins were negative. And so these patients came to us, and instead of doing radiation or taking them back for a parametrectomy, we took them back to the OR only for pelvic lymph node dissection. And obviously they had had their cervix out already, so we could not do sentinel lymph nodes. We just did a full pelvic lymph node dissection. So these are the three groups. Postoperatively, we followed the patients with pelvic exam and cytology every 3 months for 2 years. We did quality of life questionnaires before surgery, 3, 6, 12, and 24 months after surgery. And those results are being analyzed and will be reported separately. And we collected all our data in REDCap, which is a great database. This was actually our first study to use REDCap across countries, but everyone can enter their study data into a very safe, secure database that was available across countries. We had 2 stopping rules, and this was required by our data safety monitoring board. The first was the immediate failure rate, and that we defined as patients who had residual disease in the simple hysterectomy specimen who had undergone a conization followed by simple hysterectomy and lymph node assessment. And this, we had said we would stop the study if this reached 3%. So this was important because these are women who had a cone. They didn't want fertility, so they then had a hysterectomy. But if they had residual disease, it would have been a failure because we have many women who wanted just a cone, and then we would be leaving cancer behind. The second stopping rule was to look at the recurrence rate at 2 years. So we were following women for 2 years, as we said, and if they if we had 2 or more patients recur, we would stop the study. So these were the rules from the beginning. For our results, we enrolled 100 evaluable women between April 2010 and January 2019. And then we followed them all for 2 years, which is why we didn't publish the study until this year. So the study took more than 8 years to get 100 evaluable patients. And we had 14 institutions in 9 countries. So we had a lot of partners. But the study started with René Pareja in Colombia, when at that time he was at IDC. And then Gabriel Rendon was a fellow at the time, and then also joined us as well. So you can see here all the sites that we had. Most of the patients came from MD Anderson, obviously as the lead site, 36, but next was Colombia with 14. And then you can see our colleagues from Peru, Brazil, Barretos, Brazil, Buenos Aires, Sao Paulo, Brazil, Curitiba, Mexico, LBJ Hospital, which is the public hospital in Houston, where we also work. Our friends from Bangkok, Thailand, Australia, Omaha, Nebraska in the US, Argentina, Italy. So we had lots and lots of people join the study from all over the world. And it was really, I will say, the collaborators more than the institutions. Many people changed institutions during this time, especially our Brazilian colleagues, and then just reopened the study at their new institution. So again, 14 institutions in 9 countries. We had to enroll 140 patients to reach 100 evaluable patients. So 31 of the 140 patients were ineligible after pathology review. So every slide got sent to Houston. So if a patient had a cone biopsy done, we had to first review the slides in Houston before the patient could go on to have the next step with the hysterectomy or the second thing. So in all those slides, and then once I had the hysterectomy or the lymph node dissection, all those slides and blocks also got sent to Houston for review. So this was all pre-COVID. So every time we would all meet at a meeting, we spent a lot of time exchanging all the slides for Conserv. And then we also mailed them. So we had 31 ineligible after this review. 7 withdrew from the study before surgery for a variety of reasons. And then 2 patients had a positive pregnancy test at the time of surgery, so they could not undergo surgery or be included in the study. The pathology discrepancy, so those 31 patients, in almost half, 15, it was due to the presence of LVSI. 13 of them actually didn't meet the criteria because they had stage 1A1 or pre-invasive disease. And then we had 3 patients where when the path was re-reviewed, the histology was felt to be different, adenosquamous or adenoid basal, so they could not be included. You can see here the results, and this is right from the paper, but the mean age was 39. You can see actually most of the patients had stage 1B1 disease, so 67%. 48 had squamous cell carcinoma, but 52 had adenocarcinoma, so that was a little unusual. Usually, it's about 20 to 30% adenocarcinoma, so we definitely were skewed with more adenocarcinoma, which is actually, I think having more adenocarcinoma and stage 1B1 disease showed that we had a relatively higher risk group in that sense. Interestingly, most of the patients had minimally invasive surgery. So 83 had laparoscopy and 13 had robotic. And please remember that this study was carried out before the Lac Trial results were available. So at that time, we were doing all our surgery a lot of our surgery for cervical cancer with a minimally invasive approach. As far as lymph node assessment, most had a full lymph node dissection, 58%. 38% had sentinel lymph nodes plus a full lymph node dissection. And then only 4 had sentinel lymph node biopsy alone. And these were patients towards the very end of the study and mostly at MD Anderson. You can see here, again, this is right from the paper, but we had 100 evaluable patients. You can see in the next row the 3 groupings. So this was a cone followed by lymph nodes for fertility preservation, 44. Cone followed by simple hysterectomy, 40. And then this inadvertent hysterectomy was 16. You can see here we had 5 patients with positive nodes. so 5%. And then if we look at the cone with lymph node assessment, we had one patient recur, and I'll talk a little more about her. In the conization followed by simple hysterectomy, we had one patient who had residual disease, and then we had no recurrences in this group. However, in the inadvertent group, so these are patients who had a hysterectomy, then we figured out they had cancer, they came back, they had lymph nodes only. We had 2 of 16 or 12.5% who had recurrent disease. And then just to clarify, these patients, these 5 with nodes and this one with residual disease, they were taken off the study. They were still followed for results, but they obviously needed, they were excluded from further analyses to look at recurrence. You can see here, these are the 5 patients with positive lymph nodes. There's nothing different or higher risk about them. And we just show this to say, I was surprised we had 5% positive lymph nodes. I thought it would be 0, but it just reinforces the need to do lymphadenectomy, lymph node assessment in these patients. As I said, one of the 40 patients had a cone, had residual disease after the cone. This made an immediate failure rate of 2.5%. This patient had a long history of adenocarcinoma in situ. She had had previous biopsies and cones. So then she came to MD Anderson. She had a cone done that showed a grade 2 adenocarcinoma with 3 millimeters of invasion and a positive margin. So we talked to her about Concerv. She wanted to go on Concerv, so we did a second cone and ECC, and they were both completely negative. So we had positive margins on the first cone. We did a second one. It was negative. We said, okay, you're good to go on the study. And she underwent a simple hysterectomy and pelvic lymph node dissection. But she had 2 millimeter focus of residual disease. So she had a skip lesion above the negative margins. But on her hysterectomy, she still had negative margins and negative nodes. So although she had to come off the study, we decided just to do surveillance, and she was still without disease 5 years after her surgery. In the study, the median follow-up for all women was 36.3 months. 3 patients developed recurrent disease, and I'll talk about all 3 of them. So that gave a cumulative incidence of 3.5%, because obviously some patients came out of the study because of the positive nodes and residual disease. Of the 3 patients who recurred, 1 was in the group where she had a cone and then lymph node assessment, 0 in the cone followed by simple hysterectomy, and 2 of 16 or 12.5% in that inadvertent simple hysterectomy group. Just to talk a little bit about the recurrences. This is the first one. This was one of the very, very first patients on the study. She was a patient at MD Anderson, cared for actually by Dr. Pedro Ramirez and then myself as the PIs of the study. She desired fertility preservation. She had a cone done, grade 2 squamous cell carcinoma with 13 millimeters of invasion and positive margins. So we said, okay, you can go on Concerv, but you have to have a second cone first. So we did a second cone. It showed no cancer, but it did show CIN2-3 that was actually at the margins. So at that time, we didn't have the dysplasia as a criteria for exclusion. So she was okay to continue on the study. That was a big mistake in the study design. And especially now as the director of our colposcopy clinic, it's unbelievable that we didn't think of that, but we didn't. So she had a second cone, no cancer, but CIN2, CIN3. We took her for a laparoscopic pelvic lymph node dissection, 15 nodes, all negative. So per the study protocol, she comes back at 3 months for cytology, and it shows high grade. So we do a CKC. We can't really see any gross tumor, but we do a cold knife cone, and she has recurrent cancer. So probably she had persistent cancer, but now we diagnose recurrent cancer. She goes for a radical trachelectomy, and she actually has to be converted to a radical hysterectomy because there's so much tumor above. And then due to high risk features, she undergoes adjuvant chemoradiation. She's doing fine. She's NED, but obviously she lost her fertility. When this happened, it was very early in the study. The DSMB said, this is not safe, you need to stop. So we paused the study. We looked at everything again, and we talked with a lot of experts around the world. Dr. Al Covens helped us a lot. And we decided to add the criteria of depth of invasion of less than 10 millimeters to be included, and also that the cone margins had to be negative for CIN2, 3, and adenocarcinoma in situ. So we made the study even more conservative, and the DSMB let us reopen. We had not included depth of invasion because it was a little bit controversial of how important it was based on the retrospective studies. So we decided to add it. And then the cone margins was just for dysplasia was just a complete oversight on our part to not think to specify that. So we added those and went on with the study. And then the second patient who recurred was a patient with, again, a patient from Houston who had adenocarcinoma in situ and underwent a cone with negative margins. So she didn't have cancer that we knew of. She met all the criteria just to have a simple hysterectomy. She underwent a laparoscopic simple hysterectomy and had an unexpected finding of a grade 2 adenocarcinoma with 4.2 millimeters of invasion. So she had an inadvertent simple hysterectomy because by standard of care, she should have gotten a radical hysterectomy. So she enrolled in the Concerv trial, went back to the OR for a laparoscopic lymph node dissection. Unfortunately, she only had 3 lymph nodes removed. Just they thought they got more, but it ended up being 3, but they were all negative. 11 months later, she developed recurrent disease in the pelvis and in the lungs. So not in the lymph nodes, not in the parametrium, but diffuse disease. And she was treated with chemotherapy and unfortunately died 6 years after this, but lived for a long time, but on chemo most of that time. And then the last one was actually a patient from Colombia, and she underwent a cone with the findings of squamous cell carcinoma, but less than 1 millimeters of invasion and negative margins. So she had this done, she was not on Concerv, and she had a simple laparoscopic hysterectomy, which would be the standard of care. And then she had the unexpected finding on final pathology of squamous cell carcinoma with 6 millimeters of invasion. So she enrolled in Concerv at that time, underwent laparoscopic lymph node dissection with 11 negative lymph nodes, and then developed recurrent disease 10 months later in an inguinal lymph node. She was treated with chemoradiation, and she's NED at 4 years. But now we'd had 3 recurrences. So the DSMB again paused the trial and said, you reached your limit. This is not safe. But when we looked carefully at the data, we saw that the 2 of the patients had this inadvertent hysterectomy. They were on the 3rd arm of surgery, and those were the ones that were recurring. So they allowed us to reopen the study, but to exclude that 3rd group of patients. And I think what's interesting is that none of the patients recurred in the parametria, right? And that's with conservative surgery, that's what we're doing. What also happened around this time was we were starting to see the results of the Lac trial. And the Lac trial, I'll talk a little more about, but all these patients had laparoscopic or robotic surgery. And so we started to become concerned that maybe it had nothing to do with conservative surgery versus radical surgery, but instead with the minimally invasive versus open approach. Just for our adverse events, we had 2 serious events. One patient unfortunately died 26 days after surgery. It was after she had a cone and then laparoscopic lymph node dissection. A very young woman, and there was no autopsy, but we think it was due to a pulmonary embolus. So again, a very significant complication, but we don't think if she had had a radical hysterectomy or simple hysterectomy or nodes, no nodes, it was really the cause, just surgery in general. And then a patient of mine actually had significant bleeding 12 days after a cold knife cone, where she required transfusion and reoperation with sutures placed in the cervix due to bleeding. As far as fertility, we have 14 pregnancies who have been reported among the 14 pregnancies among 11 of the 40 women who underwent a cone and lymph node assessment. And of these 14 pregnancies, 13 delivered at term, and 1 had a fetal demise at 22 weeks of gestation. And it's unknown, and many had vaginal deliveries, so different than a trachelectomy. It's unknown exactly how many women have attempted to get pregnant. We've lost, unfortunately, some of the women didn't come back to us after their treatments. We don't know if there are more pregnancies than this. These are the ones we know of. So this is the first prospective evaluation of conservative surgery in low risk early stage cervical cancer. I think it's a really strong study because we reviewed every pathology specimen. It's not the real world, but it helped us make sure we were really comparing the same group of patients. We had very high quality and safety because we were monitored by the MD Anderson Coordinating Center. So a whole team that works for us was checking all the data, in touch with all our collaborators. And we had the DSMB to make sure that it was monitored for safety. The most important thing to me, and I think what René and I and Pedro and Gabrielle and all the others are most proud of, is that the trial included multiple sites outside the US and many from low and middle income countries. And these obviously are countries where the prevalence of cervical cancer is very high. And so we think our results really are generalizable and show that conservative surgery is safe and feasible, both in high resource settings and lower resource settings. Some limitations of our study is that it was a long study period of almost 9 years. There were many changes in the standard of care in that time, such as sentinel lymph node biopsy, which was implemented at some, but not all sites, and then at different time points in the study period. The surgical approach, whether it was open, laparoscopic, or robotic, varied across sites, although, as I said, most of them were laparoscopic. Our study protocol required at least 2 separate surgeries with 1 and sometimes 2 conization procedures. So again, a LEAP or a cold knife cone to confirm eligibility, followed by definitive therapy with either simple hysterectomy and or lymph node assessment. So it was a lot for the women and for the surgeons to do these procedures, but it was the safest way to get an answer to this. And then I think the other thing is that we changed the inclusion criteria during the course of the study as we learned more, but obviously that's not ideal from a study design standpoint. And then of course we have many, many questions on the minimally invasive surgery and the approach. So the Lac Trial is a study that was led by my partner Pedro Ramirez, and it was comparing minimally invasive to open surgery for cervical cancer. And it showed worse outcomes, much worse outcomes for minimally invasive. So it changed the standard of care that we now do all these surgeries open. But the Lac Trial was published during the final year of patient accrual to Conserv trial. So no changes were made to our protocol because we were essentially finished and we were still trying to digest the results of Lac. 96% of patients on Conserv underwent minimally invasive surgery. Of the 56 patients who had a simple hysterectomy performed, 40 had a cone with complete removal of the tumor before the hysterectomy. And in those patients, 0 recurred. The 16 who had an inadvertent simple hysterectomy, 2 of the 16 or 12.5% recurred. So those are patients who underwent minimally invasive surgery with the tumor still intact, the hysterectomy with the tumor still intact. And as I said, they both had MIS approach for their simple hysterectomy, and again, MIS for their subsequent lymph node dissection. So the role of MIS in conservative surgery was not, the study was not designed to answer that question. And I think we don't know the answer for these really early stage cancers. However, what I will say is these 40 patients who had a cone and complete removal of the tumor before the simple hysterectomy, none of those patients recurred. The rate of positive lymph node was 5%. So we recommend lymphadenectomy, lymph node assessment in everybody. The rate of residual disease in the hysterectomy specimen following cone was 2.5%. So I think patients who've had multiple adenocarcinoma in situ and skip lesions are probably not the best candidates for this, although we'll say that the one patient who had this had very small tumor and had no involvement in the parametrium. The 2-year recurrence rate was 3.5% overall, but again, it varied by the type. The 2.5% in the women who had a cone, then lymph node assessment, that was one patient. And again, we changed the criteria after her, and we had the next 41 did not recur. 0 patients recurred who had a cone, then a hysterectomy, but 12.5% recurred who had inadvertent simple hysterectomy. So what we conclude is that conservative surgery is safe and feasible for early stage cervical cancer, and it should be offered to all women who meet the criteria. It includes conization alone or cone followed by simple hysterectomy, both with lymph node assessment. We do not recommend conservative surgery in women who had that inadvertent simple hysterectomy. And there are 2 ongoing studies that are will be reported hopefully in 2023. One is the SHAPE trial run by Marie Plante in Canada. One is GOG 278 run by are led by Al Covens in Canada also. And these are both other different studies, slightly different, that are also looking at conservative surgery. If they show similar results, then the standard of care may change for everybody. From radical hysterectomy, trachelectomy to conservative surgery. But we are only one study and there are 2 more coming. So to be absolutely sure to change NCCN guidelines, et cetera, we're waiting for all these studies to finish. Just some unanswered questions. We don't know the long-term outcomes of conservative surgery. We don't know the role of MIS in conservative surgery. We don't know if doing this conservative surgery really had a good impact on quality of life. We think less radical is better, but we also ask the patients. We don't know the best management of women who have an inadvertent simple hysterectomy with post-op diagnosis of cancer. All we know is that our approach was not good with a 12.5% recurrence rate. We are always redefining low risk. You know, for us, it was less than 2 centimeters. Then we added the 10 millimeters of invasion, no LVSI, but we need more and more data to figure that out. And then we still haven't determined the exact role of neoadjuvant chemotherapy for patients who don't meet these criteria. So there's an ongoing study now, the Contessa trial, where if women have a tumor bigger than 2 centimeters or other risk factors, they can get chemo first and then conservative surgery. I think just some final thoughts that the Concerv trial findings will hopefully spare women the early and late morbidity of radical surgery. It will allow for safer surgery where there are not specialists. So in lower resource settings where there aren't well-trained gynecs. And obviously those are the areas where there's a higher burden of cervical cancer. And I think what has been most exciting and most gratifying is that we built a robust network of collaborators around the globe, facilitating a pathway for future treatment trials with participants from regions with a high burden of disease. So this trial really allowed us to work together and to figure out how to do studies across countries to be able to answer the questions for all our patients. I want to say an especially big thank you to Renee and Pedro. We started this trial, as I said. My children were like little kids, and now they're teenagers about to go to college. But Renee was an amazing partner from the first day, and Pedro was a fantastic mentor in really getting this trial up and running. And we had many problems over the 10 years. And then you can see us in September 2019, so 9 years later. We all aged a little bit, but this was at the IGCS meeting where we presented the results when they finally became available. So just amazing friends and colleagues to do this study with. And then here is a picture of many members from our team who were able to be in Brazil for IGCS just before COVID. And then an especially big thank you to our research coordinators at MD Anderson, Cindy, Jessica, Anna, Juana, and Katie. They were on the phone, on Skype, on WhatsApp with all our collaborators all over the world in the morning, in the afternoon, at night, to really solve the problems and to make the study happen. So really amazing, and thank you to all our collaborators and to the sites, but and especially to Renee and Gabrielle for all the help in Colombia. And with that, I'll end.
Okay, thank you, Dr. Schmeler. That was a wonderful presentation. Congratulations for this excellent study that, as you mentioned, it took surely a lot of effort from a lot of colleagues from many countries and for so many years. It's really an outstanding work, and it's really being a study with various strengths, as you mentioned, like meticulous selection criteria, as having the review of the pathology, that I think that's like a really big effort, and also a great work from the safety monitoring committee. So here we have various questions for this last minute. Okay, so the first question is, though there isn't a universal definition for negative margins in the cone specimen, the NCCN guidelines suggest a 3 millimeter free margin for patients with colonization for fertility sparing management. But the inclusion criteria in the Concerv trial was 1 millimeter. So do you think 1 millimeter should be adopted instead of 3 millimeters, or what are your thoughts on that?
Yeah, I don't know. Interestingly, when we wrote the study, we didn't put a definition. We just said negative margins. And then it came, well, how do we define a negative margin? So we went to our pathology colleagues. You know, I think we have 8 gynecologic oncology pathologists at MD Anderson. And we talked to our colleagues in other countries and other places, and nobody could agree. And it was before the 3 millimeter definition. And the group at MD Anderson thought that 1 millimeter was adequate. I don't know the answer to that. Probably the 3 millimeter is a safer one. The problem is with these cones, especially in a small cervix, that can be hard to get. So I think there's no known answer. None of our patients recurred, but we have not gone back and looked at that, but we certainly could, because we reviewed all those specimens. So it's actually a great question that we can answer with our patients, because I think we're going to find very few that only had 1 millimeter. Usually it was more, but if we did and it looks safe, then it's okay. But the answer is I don't know, and I definitely defer to my pathology colleagues if they have any more information about this. But it's a good point. We should, I'll talk with our pathologists to see if they would be interested in looking back at all of ours and see what our margin status was. They'll have to look at all the slides again, because I don't think they normally do not document how many millimeters it is.
Okay, here's another question regarding discrepancies in pathology review, specifically talking about the presence of lymphovascular space invasion. Do you know if the expert pathologists frequently use immunochemistry like endothelial markers, CD31, 34, to aid in the diagnosis where there are difficult cases?
I don't know how often they do, but that's their standard at MD Anderson to often do that. And throughout the study, all the other sites had to send us not just slides, but blocks as well, so that they always had the opportunity to do these additional tests. I will say that, and I already forgot what the number was. I think it's 13 patients. There was a large number where the review by the home pathologist was LVSI negative, and then we read it as LVSI positive. And I talked a lot with our pathologist because we were getting really frustrated because they kept finding LVSI that wasn't seen by the primary pathologist. And finally, one of the pathologists told me, if you keep looking hard enough, you'll find it. So I think it was, obviously the patients were on study, so there was a lot of review. But I'm not a pathologist, so I will say that was something that we saw, and it's something that I see all the time with our patients. We have a lot of patients who come for a second opinion, and they get from everywhere in the US, and they get their pathology reread, and it's common all the time, no matter where the pathology is read. It's read in Chicago or New York, and then when our pathologists read it, they often find LVSI that was not seen elsewhere.
Okay, thank you. Okay, we have another question over here. Okay, is it always needed an endocervical curettage when doing a conization outside of Concerv?
No. So if it's for dysplasia, we no longer do it. So in our colposcopy clinic, we don't do an ECC above the cone unless they have adenocarcinoma in site 2, and then because of the skip lesions. But for cancer, because a cone is not standard, and even now with Concerv, it's becoming standard, but we still do an ECC above just to be sure, even with squamous, because especially if we're not going to do a hysterectomy.
Okay, thanks. Okay, do you think the Silva pattern can affect the possibility of conservative management and the type of procedure?
Yeah, I think that's a great question. So the Silva pattern is actually developed by Elvio Silva, who is a pathologist who he's still at MD Anderson. He's retired, but he still works part-time. But he's a world-renowned pathologist originally from Argentina, who has published on the Silva pattern of looking at how helping us see that there may be some less aggressive versus more aggressive adenocarcinomas. So the answer is I don't know. That wasn't part of the Concerv study. The Silva criteria are relatively recent. But again, I think it's a great research question to go back and look at all our samples and categorize them now via Silva to see. But I think sort of in my slide of unanswered questions we are constantly going to be revising, I think, what's considered conservative surgery as we learn these new factors. Maybe we'll have more biomarkers or blood tests or cervical staining or something that will help us figure out what's aggressive and what's not.
Okay, great. And in the same line, do you think if you look at the patients, if they are HPV associated, cancer HPV associated or not, like in the new classification, do you think, what are your thoughts on that? You think that it's going to be relevant for conservative surgery?
Yeah, it's a great question because I think we're still trying to figure that out, right? We went from not knowing the cause of cervical cancer to saying all cervical cancer is HPV related. And now we are learning that there's a small group of patients where it's HPV independent cervical cancer, but I don't think we know enough about it yet to know. I certainly don't know enough about it yet to be able to make that determination. And again, I think it gets back to we're going to keep refining and refining to figure out who's low risk and who's high risk. You're muted.
I'm sorry. Okay, we have another question. In patients with repeated conization, was the depth of the invasion added within the cones to determine the depth of invasion, or you don't do that?
I'm sorry, can you repeat it?
Well, for patients who went to 2 cones, yeah. Did you add the depth of invasion, or you just didn't add it, or how do you describe like the 10 millimeters?
Yeah, it's a great question. So when I was a fellow, we used to just add it. And then our pathologist, Mike Devers, another one of our great pathologists, said, you can't do that because how do you know it's right in the same area? Maybe you had 2 millimeters here and 3 millimeters here, or maybe you had 2 millimeters and 3 millimeters. So the pathologists say that we cannot add it. Most of the patients had 1 cone that showed cancer with positive margins, and then the second cone was usually negative, probably with a cautery, et cetera, did that. But that was essentially how we decided. And if it added up to more than 10 millimeters, we just decided the patient was probably too high risk, even if they were in 2 different places. But there's not a good, as far as I know, there's not a good way to figure that out. And maybe, again, that would be a good study. One of the things that René has been very interested in doing is looking at those 40 patients, or 20, I guess not quite 40, but the patients who enrolled in Conserv, but then were not eligible because of pathology findings, to look and see what happened to them. Because we said, you're not on the study, whatever your doctor wants to do. And many times the doctor, I think, still treated them conservatively. And if not, it would be really good to look at those patients. The problem we have is they're not covered under our IRB because they did not go on the study after that. So we didn't say we could follow their outcome. So we just have to do another IRB protocol and be able to get their slides and bring, back to Anderson afterwards, or maybe however. But it's a great question that we don't know the answer to.
Okay, great. We have another question. If you could remind us how were the outcomes of the patients with adenocarcinoma? Did they have more recurrences?
No, not at all. So the recurrences were, the one with residual disease was an adenocarcinoma. The other 2 recurrences, 2 were squamous and 1 was adeno. So we didn't, and we had a lot of adenos, right? We had more than 50% adenos. So, and the same with the lymph node involvement, they were almost all squamous. Okay. So as far as we saw, but please remember, we excluded grade 3 adenocarcinomas. It was only grade 1 and grade 2. And that was from a small study at MD Anderson that showed they might do worse. And at the time, I mean, again, think about it. This was 2008, 2009 when I was writing the study. It was very controversial to do conservative surgery. So it was felt to not be safe by my own partners in the department at MD Anderson.
Yeah, of course, it wasn't easy. Okay. Okay, we have another question here. In your current practice, how do you treat patients with low risk early stage inadvertent cervical cancer in hysterectomy? So I want to know, do you prefer the surgical approach that includes the parametrectomy? And if so, what are your thoughts on the concept of various authors of retrospective studies that suggest that parametrectomy might be obsolete because rates of residual disease in parametrium and vagina are very low, and also taking into account that in the Concerv trial, no recurrences were seen on the structures?
Yeah, so I think that it's a great question. We don't know the answer. I saw a patient last week. We talked about it in our tumor board. Nobody knows what to do. I think that doing a parametrectomy is of little value if they meet these conservative surgery, the low risk criteria. And that's because, as you said, we didn't see any recurrences in the parametria. And a parametrectomy is not an easy or enjoyable operation, right? It's very, very challenging to do. and you need very, very skilled surgeons, which most of the world doesn't have. So I think doing a parametrectomy is, I think, in my opinion, is probably a surgery that may become obsolete. I think that we still don't know the answer. I think we have a lot of clues from the Lac trial that maybe if patients had an MIS approach, that they are at risk for recurrence. So we are doing a lot of radiation in those patients. Or if they truly seem low risk, then I think it is, maybe you can observe them. But again, I think important is to know their lymph node status. 5% of patients had lymph nodes involvement. So we haven't seen very many since Concerv got published, but my one that I have seen, we have decided to give her radiation.
Okay, great, thank you. Okay, regarding this last question and the recurrences that didn't involve the parametrium, it wouldn't be completely clear whether these cases were truly due to limiting radicality, right? So is there other hypothesis for the presentation of these recurrences? I believe you mentioned the minimal invasive surgery. Can you
Yeah, I think it's the minimally invasive surgery. And again, from Lac, we don't know why. Mm-hmm. Is it the manipulator? Is it it's all the different things. But, both those patients had disease outside of the parametrium of the pelvis. One was an inguinal node and the other person was lung and peritoneal disease. So I don't think it was because of conservative surgery, but we also will never know. Okay. They had negative lymph nodes, both of them. It's hard to say, but they didn't recur in the lymph nodes or in the parametrium or even in the vagina, right?
Yeah. Okay. What are your thoughts on the latest study from our Italian colleagues and further analysis of the Sucro trial, where they suggest a protective role of conization before radical hysterectomy in early stage cervical cancer?
Yeah, I don't know the details of the studies well, but what I will say in our group, where the 40 patients who had a cone with removal of all of the tumor and then a simple hysterectomy did great. And in the ones that had a cone and then just lymph nodes, only that one recurred very early on, who was not a good candidate for the study based on our new criteria. So I think that if we are going to do this, I think it needs to be important to remove that tumor with a cone before we do it. I think we also shouldn't mix all the studies, right? There's a lot of interest in continuing to try to show the Lac results are not, are not correct. Not that they're not correct, but that they're, there is something else. But Dr. Ramirez at the SGO meeting just presented the longer term follow-up, and the results are not good. And for us, we're not participating in any trials that are doing MIS in cervical cancer, because it's hard for us to explain to our patients that we would potentially put them at risk, even on a trial. But we definitely feel strongly you should not do it unless it's on a trial, and we really struggle with the ethics of the trials.
Okay, yeah. Okay, we're almost out of time, but I have another question. Okay, have the results of the Concerv trial changed, like at the moment, your personal practice? Should everybody take into account these results to discuss with patients case to case to offer conservative management in this moment, or should we definitely wait for the results of the SHAKE trial and the GOG 278 trial?
So what we have decided as a department at MD Anderson, we're like 23 GYN oncologists. So we met once we had the final results and published them. And what we are doing at MD Anderson is any patient who meets this criteria, we are discussing with them the results, the study, that the study's not perfect, but it's prospective. It's a well-done study. and that we feel it's safe, but it is still not the guidelines. So we give the patients a choice. I had a patient like this actually a month ago, and we explained the study. We gave her a copy of the study, and we said the standard of care is a radical hysterectomy, but you meet the criteria for this. And so we talk to the patients about it, but we also say that there are 2 more studies. We're waiting for all the results, and then we'll work with depending on if the results are good, then probably the guidelines will change, but they haven't changed yet. So we offer it with the added explanation that it's not the standard, but that we feel it's safe and appropriate.
Okay, yeah, and we have this last question from the audience, I believe. This question, wait a second. Oh yeah, if you consider that the conization was safe for one of the patients that recur, like giving it another shot for conization of this patient that recur.
Oh, you mean in the one case we had that recurred?
Yeah.
The only reason we did the cone was we didn't have a diagnosis. We had a PAP that was abnormal, but just for dysplasia. We didn't know that she had cancer until we did the cone, and then the cone came back with cancer. Because we did a PAP and an ECC and colpo, and we had no cancer. So we thought she just had CIN because she had margins positive for CIN, but then not only did she have a cancer, she had a cancer that was even bigger than we thought, and then needed a radical trachelectomy, and then needed a radical hysterectomy, that needed radiation. So in retrospect, when we reviewed the case, she was not a good candidate for conservative surgery. We learned a lot. Unfortunately, we put her through a lot, but we learned a lot from that case about patient selection and what we were doing.
Okay, so that's about the questions we had. Thank you very much, Dr. Schmeler. That was an excellent presentation. Thank you for answering all of our questions. We know there are very things that we cannot answer yet, but thank you for trying to do so. And nothing, just to congratulate you again for an excellent job.
Awesome. And thank you so much to the society and to all the leaders. It's really an honor to talk with all of you tonight. And I look forward to coming to Colombia again soon one day.
Yeah, sure.
Okay, thank you. Thank you, Dr. Kathleen. It was very, very interesting, your conference and all the answers for our questions. I hope all the audience is very, very happy with you. Y bueno, para los que si hay alguna otra pregunta que quieran hacer, todavía podemos hacerla, o si no, pues nos vamos a despedir agradeciéndoles a todos su asistencia a esta conferencia. Y doctora Kathleen, we hope we will meet someday, if not in Colombia, maybe in the IGCS in New York.
Yes, we will be there, definitely. Please come.
Okay.
So, okay. And in the US today, I don't know if it's everywhere in the world, but today is Doctor's Day. So happy Doctor's Day to all the doctors who are on. Yeah.
Happy day to you.
My husband, who's not a doctor, says every day is Doctor's Day, but today is a special day.
Okay. In Colombia is the December 3.
Okay.
Okay. Happy day to you, doctor.
Okay. Bye-bye. Thank you all.
Good night. Thank you.
Bye.